Okay, so thinking back to before spring break, we were working through our spinal cord lecture, kind of talked about the external anatomy, just as the spinal cord as a whole. Then we talked about the kind of internal anatomy of the spinal cord, where we have the white matter on the outside, the gray matter on the inside, forming kind of a capital H shape. We learned that there's different segments to both the white and the gray matter, where you have in the white matter these different columns, like this posterior white column, the anterior white column, two lateral columns. And then when you look at the gray matter, you have these what we call horns. Okay, and there are two dorsal or posterior horns, two anterior ventral horns, and those are associated with the different roots of our spinal nerves. And that's where we left off talking before break about these roots, which connect to the spinal cord. But then when the spinal nerves emerge out of the spinal column, like in this case right here, those different spinal nerves branch and form what we call rami, or the singular form of rami is ramus. Okay. Two major rami include the posterior and the anterior. There's also a meningeal branch, and then what we call the communicating rami. But as you can see, the anterior rami on both sides here are much larger than the others. And that's important because those often form what we call plexuses. And there are 5 principal plexuses, which were visible, and I kind of referenced them a couple different times early in the lecture. We have what we call the cervical plexus, the brachial plexus, lumbar, and then the sacral and coccygeal plexuses. Okay. And as you can see here in this illustration, these plexuses are just like a network of these different spinal nerves coming together, especially like looking here at the brachial plexus, you can see like C6, C7, whatever, they're coming out and then they come together. So instead of forking away from one another, they come together, so they converge. And then eventually coming off of that network are nerves. And you can see like listed here under the brachial plexus are these 5 nerves. Okay. That's what we're going to transition to talking about right now, beginning with the cervical plexus. Okay. Cervical plexus supplies the skin and muscles of the head, the neck, superior portions of our shoulders, as well as the chest, and then the diaphragm. So in other words, cervical plexus, which is up there in your neck, is going to supply a lot of stuff up there by your neck, like your head and the neck, your shoulders, the upper chest, but also, which kind of seems weird, but the diaphragm, which is that muscle that we previously learned about, that is responsible for us being able to breathe. There's one specific nerve that's going to innervate that diaphragm, and then I'll talk about that in a second. Forming this plexus are the roots of the first 4 cervical nerves, so C1 through C4, with smaller contributions from C5. We have cervical plexus on each side of the neck along the first 4 cervical vertebrae. And coming off of the cervical plexus are several superficial and deep nerves. And that's what we have listed here in our table at the kind of middle part of the page here. They've broken it down into superficials and then deep. And the nice thing about this table is it gives you the name of the nerve, where it's originating, so which spinal nerve, like in the case of the lesser occipital, comes from spinal nerve C2. And then it tells you what it does. As far as innervation goes, lesser occipital is going to innervate like the skin of your scalp on the posterior side of our head and superior to your ears. So in other words, like if you rub the back of your head and you're feeling that rubbing, you're stimulating your lesser occipital nerve. Okay. Some of these are more specifically related to sensory function. In other words, like, transmitting that sensation of touch or itch or tickle. In the case of these deeper ones, as you can see in parentheses, largely motor, that tells you they're more involved with signals going out from the spinal cord and thus are associated with contracting skeletal muscles, like in the case of the superior root of the ansa cervicalis, hitting these various muscles of the neck, or the phrenic nerve, which is the one that innervates your diaphragm. And phrenic nerve's absolutely essential to being able to breathe because without your diaphragm contracting, you can't inhale and you can't exhale. So if you lose your phrenic nerves, you're in bad shape. As far as these tables go, I'm not going to ask you anything specific about like what the nerve does. So I'm not going to ask you to know, what origin or description. The only exception to that rule, and that'll be the case for all of these, I do want you to know the phrenic nerve, okay, and that it innervates the diaphragm, and that's just because that's so important, obviously. And it's a life and death type nerve, obviously. What I will ask you for sure on the exam is stuff like, which of the following nerves is a nerve of the cervical plexus. So I want you to know that these are the nerves that belong to the cervical plexus. Does that make sense? Okay. Now, looking here at the bottom of the page is an illustration showing you one of the two cervical plexuses, the one on the right side. You see where it's shaded yellow, that's the root coming off of the spinal nerve coming from the spinal cord. And then in green here, they show how they come together. And then eventually, as you can see, they diverge from one another and they form those various nerves. Not an image that you will absolutely need to know. You'll see one of these for pretty much all the rest of the plexuses, and it'll be the same situation. I'm not really worried about this image. It's in your textbook, and it's kind of cool to see. Nothing really specific, though, that I've asked you to worry about. With that said, I do have a picture of one that we can color, and that's what I'll do here. It doesn't give us all of those nerves, like you can't see the phrenic nerve running down to the diaphragm, but we can see several of them, and so we'll do that now. And this image, since I'm coloring it, would be one that would be fair game for the exam. It is the only one that we will color, okay? So it's nothing too crazy as far as coloring in this lecture goes. We can't see them all, like I said, but we can see a few, like this great auricular, okay? The lesser occipital. I will color that kind of green color. Transverse cervical, and then the supraclavicular. Now, based on their name, if you kind of pay attention to what it is, it's going to tell you where that nerve a lot of times is going to be found. Okay, we haven't talked about the ears yet in this class, but the fancy term for your external ear, the part of our ear that we can, feel, get pierced, that kind of stuff, that's your auricle. And there's a nerve right there that's just about touching your ear, and that is that great auricular. And so I will color that one as such. Now we all know, hopefully by now, the back of your skull is your occipital region, where your occipital bone is. And I've already kind of talked about this, but innervating the back of your scalp, there is that lesser occipital nerve. Yeah. Cervical region, we all know, hopefully by now, refers to your neck. And the word transverse means like going horizontal or across, which is what this transverse cervical nerve does. Kind of goes horizontally in that area we commonly call our throat. And then our largest nerve here visible actually has three parts to it. You can see they're labeled there: medial, intermediate, lateral. Not that that's really important. Is the supraclavicular. We've seen that prefix supra several times. Clavicular for clavicle. That's, you can see right there where that nerve runs by. Like I said, we can't see all the nerves that were there listed on that table on the previous page, but we can see 5 of them at least. So a decent view to show some of them off. Like I said, this is the only image that we'll color. The rest of them, there are pictures from your textbook that we will use instead. I don't even know if there are pictures in the textbook for the cervical plexus for whatever reason. There might be, but I don't remember, to be honest, off the top of my head. Okay, so that's your cervical plexus. Moving on. Talk now about the brachial plexus and the nerves involved with it. Okay, your brachial plexus supplies your shoulders and your upper limbs, formed from the anterior or ventral rami of C5 through C8, as well as T1. Now, in the case of the brachial plexus, we have some kind of unique conversion going on where we form what we call trunks and cords and divisions. And so we'll talk about that now, okay? The roots of several spinal nerves unite to form trunks in the inferior part of the neck. Root C5 and C6 converge to form what we call the upper trunk. C7 is the middle. C8 and T1 converge to form the lower trunk. And those are shown here kind of in this peach shaded color, okay? Posterior to the clavicle, so behind your collarbones, the trunks divide and form divisions, and there are two, anterior and posterior, and those are shaded here in kind of this, was it kind of like a light green, and then kind of more of an aqua color. And then coming off of those divisions, those merge and form three fiber bundles we call cords, and there are three of those: lateral, posterior, medial. And from these cords, the actual nerves of your arms arise, okay? And as you can see, there are several of them, okay? Some of them are much more important in my opinion. Obviously, they're all important in their own right, but things like your median, your radial, your ulnar, those are gonna run all the way from your, your shoulder down into the tips of your fingers and innervate various things throughout your arm, okay? As far as this table goes, I would say I'm going to tell you kind of the ones that I really want you to focus on. So I'm not going to require you to know all of them. So here's the ones I would put a star next to or highlight. We'll start with the musculocutaneous. Then I'll skip down to axillary, median, radial, and ulnar. So I'm going to kind of cut the table down quite a bit. And a lot of it is because of what we can see here on the next page. Now, speaking of this picture here on the next page, this is an illustration of why I like coloring, where you have everything in the same color and you got a lot of different lines. It's really hard to kind of tell things apart. I just haven't really found a good picture to color for the arms and legs. But I promise you, if you see this image, which there's a good chance that you will on the exam, what I will do is I will include arrows already pointing to the structures, to the nerves that you would need to know. So you're not going to have to draw an arrow. Okay. And what I would not do is, have you label really any of these right in there where things get really hairy. Okay. What I want you to highlight is the following. Starting on the left side, I'm going to have you highlight the axillary nerve, but I'm going to zoom in. We know our axillary region is our armpit, right? And that's right where the axillary nerve is labeled. If you look here, though, you can see this nerve all the way there on the outside of the shoulder, right underneath the deltoid. That's also the axillary nerve. So if you really wanted to kind of draw your own arrow or just like circle it, might not be a bad idea. It's where you can kind of tell it apart a little bit better from the other ones. And if you've ever been on crutches before, and one of the things they tell people that have never been on crutches before is like not to put all your body weight on the actual crutch. You should always have a little bit of room in there, or put like some towels or something, some padding in there. Look at all those nerves. If you push too much pressure on their body weight, can cause nerve damage actually, and that would be detrimental, obviously, to your health. So. Okay, moving down, I do want you to highlight the musculocutaneous here that you can see in kind of the front of the humerus muscle there. The radial, the median, the ulnar nerve there, you can see are highlighted up there, identified up there. But if you look down here in the forearm, you can also see them labeled. And that's where I would highlight them. That's where I'd ask you to know them. They do originate up there, but they run down through the forearm. And that's where you can kind of tell them apart the best. And if you use your knowledge from what we learned previously, where the radius is, where the ulna is, it's going to make it a lot simpler. Okay, we all know the ulna's on the pinky side, and that's where that ulnar nerve runs. Okay, that's the one that innervates, like the pinky and your ring finger. And if you hit your elbow on the table, you funny bone, as they say, that nerve right there might get stimulated. And actually, if you kind of feel around for it, sometimes you can stimulate it. The radial nerve runs on the other side of the forearm down the radius, and then in between them is the median nerve, and that's another big innervator of muscles in your and stuff in your hand and fingers. So those three down there at the bottom of the image, nothing else as far as the branches or any of these down in the floor in the hand or fingers I'm going to worry about you knowing. So really it looks like an awful image, but I've simplified it hopefully for you guys where it's not too terrible. Sound good? Okay, moving on to the lumbar plexus. It's what supplies the anterolateral abdominal wall. So the front and the sides of your abdomen in that wall, the external genitalia and the lower part of your lower limbs, or part of the lower limbs, I should say, not lower part, but part of the lower limbs. So in other words, your legs. It is formed by the roots of spinal nerves L1 through L4, but unlike the brachial plexus, and you can really see this, there's not as much intermingling and merging going on. So we don't have those cords and divisions and whatnot like we did in the brachial plexus. Coming off the lumbar plexus are the following major nerves. And there's what, 6 of them. And I do actually want you to know all 6 of those. And like I said, you don't really need to worry about what they innervate or anything as a whole. I kind of just, give you a brief description of it at the top. That's as in depth as you really need to go. But we have the iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous, femoral, and obturator. We look here on the next page. They've included, or I've included, I guess, it's figures from your textbook, an anterior view and a posterior view of essentially from the lower back to just above the knee. And we can see some of those same nerves that were just listed, along with some nerves that aren't listed, like the sciatic nerve that you may have heard of before, like the pudendal nerve that you probably haven't heard of before. I'm going to actually not highlight anything quite yet or tell you what to highlight, because if you look a couple of slides ahead, it's essentially the same image, but then it also includes the legs all the way down to the tips of your toes. And this is an image that gives you a view of the lumbar, but also the sacral and coccygeal plexuses. So if I told you to highlight those things, I'd tell you to highlight them again. I'm not going to put these 2 images on the exam. If I were to put any of the images, I'd put the ones where you can see all the way down to your feet. Does that make sense? Okay, so let's talk about the sacral and coccygeal plexuses. Sacral plexus supplies your butt muscles. The perineum, remember the perineum is like the bottom or the floor of your pelvic cavity, and then your lower limbs. Formed by the roots of spinal nerves L4 and L5, as well as S1 through S4. Okay, your coccygeal plexus supplies a small area of skin in the coccygeal region. So kind of at the crest of your kind of butt crack, for lack of a better way to describe it, formed by the roots of spinal nerves S4 and S5. Okay, following nerves arise from these plexuses, and as you can see, there's several of them. Okay, as far as what you'll want to know, it's kind of what I did with the brachial plexus. I'm just going to tell you a few of them to know, not all of them. So highlight these. I want you to know the superior and the inferior gluteals. Those are very important because they innervate your butt muscles, your glutes, as we know. I'll skip down to the perforating cutaneous, posterior femoral cutaneous nerve, pudendal, which I mentioned a couple seconds ago, the sciatic, which is actually the largest nerve in the body. There's 2 of them actually, so sciatic nerves. But as you can see listed over here, it says it's actually 2 nerves, and that's what we see here, tibial and common fibular. If I go back, actually, I'm going to jump down to the next page. Your sciatic is big, fat, yellow one here that then just above the knee comes to a fork. Okay, one of those is the tibial nerve. One of them is the common fibular nerve. Okay, now the tibial nerve runs down the tibia. Fibular runs down the fibula, hence their 2 names. But anytime you see this term common when it comes to nerves, and we'll see the same thing when we talk about blood vessels here in a few weeks. That tells you that there's another fork in the road coming, and we can see that right here. The common fibular nerve is this nerve here that then becomes what we call the deep fibular and the superficial fibular. Okay. As far as the image goes, I'm not going to worry about these two, and I'll get to that here in a second. It would just be the common fibular that I would want you to know. Okay. So don't worry about highlighting the medial plantar, the lateral plantar, the superficial fibular, the deep fibular, but I do want you to know the sciatic and then the tibial and the common fibular. Okay, and then like you said, look at here, you don't see nearly as much branching as what you saw in the brachial plexus, a little bit more branched and intermingling than what we saw with the lumbar plexus. Look at the size of that sciatic nerve and all the contributions that are coming in to form it. A little bit here, not much for the coccygeal plexus, but it is important nonetheless. Okay, now we can actually talk about what I want you to highlight or star. So I'll just start here on the left side and I'll do these, and then I'll get to the middle, and then I'll get to the far right. Keep in mind, this is the anterior view. The figure on the right is the posterior view. And we're highlighting stuff not just from the sacral and coccygeal plexuses, but also from the lumbar plexus. Okay. So what you need to know includes the iliohypogastric, not to be confused with the ilioinguinal, genitofemoral, lateral femoral cutaneous. I'd love for the obturator to be one, but it's just kind of too hard to tell when you got all this stuff going on in the middle. So let's skip it. I'll move to the middle here. I do want you to know the femoral. I do want you to know the pudendal. Really, the posterior view is where you get the best view of that, but they do label up there, the anterior. Definitely know the sciatic. That's that big one there. You can see in both images. And then down in the kind of lower leg area, the tibial, and then the common fibular. As far as the rest of them go, and the tibial again, don't worry about it. Just up here is where I'd ask you to know it. And then over on the right, in the posterior view, we can see, and I do want you to know the superior and the inferior gluteals, and then the posterior femoral cutaneous. Like I told you guys just a few minutes ago on the exam, you're not going to just have these blank images where you'll have to draw in the arrows. The arrows will be provided for you. It wouldn't be a whole bunch. Maybe you had to choose, 2, 3, 4 nerves to label. So it's not going to be the worst thing on the planet Earth, and the worst thing I've asked you to do this semester. Sound good? All right. Let's talk about dermatome. It's one of the coolest things we get to talk about because it involves something you probably have seen in movies, TV shows before. Okay, our skin over the entire surface of our body is supplied by specific somatic sensory neurons that carry the nerve impulses from our skin to the spinal cord or into the brain. Okay. Each spinal nerve contains sensory neurons that serve a specific predictable segment of the body, and that area of the skin providing sensory input to the central nervous system via a specific pair of spinal nerves is called a dermatome. So in other words, what we have mapped out here in the illustration is the specific part of our skin and what spinal nerve is involved with it. So like in the case of the back of your skull, you know that if you touch the back of your skull where somebody else is, and you scratch it or you itch it or you tickle it or you pull hair from it, you're stimulating nerves that are eventually relaying that information to the spinal cord via spinal nerves C2. Okay, it's a very predictable thing. Okay, there is an exception. Okay, and that's because your face is not innervated by a spinal nerve, but instead is innervated by what we call the trigeminal nerves. Okay, trigeminal nerves are a pair of your cranial nerves. Okay, and they carry the signal directly to the brain because that's what your cranial nerves connect to, your brain. Whereas every other place in the body, it's the spinal cord and a spinal nerve, like L2 that I'm showing here, CA. Now, why is this important? Well, knowing which spinal cord segment supplying each dermatome makes it possible for doctors or physicians, as they're more specifically called, to locate damaged regions of spinal cord. If you've ever seen a movie where somebody is in a hospital bed and they're checking like the bottom of their toes and they're pricking them, they're tickling them, they're saying, "Do you feel this? Can you feel that?" Okay, they're testing this. Okay, they're seeing if the spinal cord is damaged, for example, where S1 connects to it, okay? Or if they're touching their thigh, they're checking for the lumbar region and L2 spinal nerves. Does that make sense? So doctors are going to be very aware of this, and that's because it's very predictable and it's nicely mapped out. Some very, very smart scientists, doctors, were able to figure that all out, map it all out so that it can be used for diagnostic purposes. Hopefully something that nobody ever has to experience, finding out if their spinal cord or their spinal nerves are damaged. All right, I'm going to transition quite a bit here from what we've been talking about to something very different, but something we've talked about before, which is that autonomic nervous system. And that's one of those divisions of our parasympathetic nervous system, or not our parasympathetic, but of our peripheral nervous system. So the wrong P word there. And remember, the peripheral nervous system, once again, is the division of our nervous system that does not include the brain and spinal cord. So it's everything outside the brain and spinal cord, which includes those spinal nerves and those cranial nerves that I've mentioned. Okay. And then you can take that peripheral nervous system and you can divide it into somatic, which is associated with like controlling your skeletal muscles and does so in a voluntary manner. And then the autonomic, which is associated with controlling things involuntarily, or as I say, automatically, things like your cardiac muscle and your heart, the smooth muscle that's in things like your bladder and your stomach, your intestines, and then various glands. Okay. Now, we can then subdivide the autonomic nervous system, as we've previously learned, into two divisions, two majors. There's actually a third, but those include the sympathetic and then the parasympathetic. Remember, the sympathetic produces what we call a fight or flight response. That's what is active, like if you are in a life or death situation, like running from a bear or fighting a bear, or something not life-threatening, like just going for a jog. Parasympathetic division is what's active in you guys right now, as well as myself, because we're kind of in a rest and digest, maintaining kind of just resting homeostasis. Okay. Unlike the somatic motor neurons, which are the neurons that extend from our central nervous system to our skeletal muscles. Okay. In the case of those nerves actually originate either in the brain or in the spinal cord and then run all the way to the skeletal muscles. Okay. In the case of the autonomic nervous system, it takes actually two nerves to get to the organ. Okay. What we call a pre and a post ganglionic neuron. And it's kind of hard to see, but if I zoom in, especially like right here, we can see one neuron coming out of the brain and then another neuron going the rest of the way to the eye. And if you don't know by now, the prefixes pre and post mean before and after. Okay. The first neuron that carries the signal out of the central nervous system is called the preganglionic neuron. The second neuron that carries it from there to the organ that's being innervated is called the postganglionic neuron. Where they meet is what we call autonomic ganglion. Okay. And like this terminal ganglia here that's labeled, that's just a fancy way to describe where the two neurons synapse, where neurotransmitters are released. Okay. So it takes two neurons to get to the organ that's innervated in the case of both the parasympathetic and the sympathetic. Okay. If this was an illustration showing you the somatic, which once again controls skeletal muscle, one neuron can run all the way from the brain to the spinal cord to the muscle that's being innervated, which can be pretty long, like in the case of the muscles in our toes, muscles in the tips of your fingers. Those neurons originate in the spinal cord and have to run all the way through your arms and your legs to get to the muscle that they cause to contract. So it's really cool but it's not the way that it works for the sympathetic and the parasympathetic nervous system. Now, looking at this illustration down here at the bottom, we show the parasympathetic on the left and the sympathetic on the right. If you haven't kind of picked up on it, the sympathetic and the parasympathetic involve kind of different parts of the brain and spinal cord. In fact, the sympathetic nervous system doesn't involve signals coming directly from the brain. It's all from the thoracic and lumbar region of the spinal cord. The signal originates in the spinal cord and then it comes out. And in most cases, the second neuron and the first neuron meet in this trunk or chain, which is on both sides. There's only one shown, but there's two of them. These chains are on both sides of your spinal column. So this illustration doesn't show it, but we obviously know that surrounding our spinal cord will be vertebrae. So they've taken the vertebrae away. But most cases, the signal comes out and then a synapse occurs, and you can see that like right here. And then from there, the second neuron runs the rest of the distance. So in the case of the sympathetic, it's typically a really short first neuron, the pre, and then a very long post. Okay. Whereas with the parasympathetic, it's typically a very long pre and then a short post. Now I'm getting really in the weeds here, more physiology stuff, but I kind of wanted to introduce this to you guys. Okay. Looking at the parasympathetic, I mentioned the sympathetic is strictly the thoracic and lumbar regions of the spinal cord. Your parasympathetic utilizes some of our cranial nerves, which are the nerves here listed with the Roman numerals associated with them. And we'll get into those in our next lecture when we talk about the brain. And then it also uses the sacral region of our spinal cord. So what I'm kind of getting at is that although these are the same part of our nervous system, the autonomic nervous system, they produce very different effects. Like sympathetic makes you, able to run. Parasympathetic makes you able to rest. And they also involve different segments of your nervous system, different segments of your brain, spinal cord versus just the spinal cord as a whole. Okay. So there's a lot of information in here. I kind of just said it as I was talking. I didn't really read it, but that's okay. Don't get too worried about all that information in there. Just kind of the major points that are listed. And you don't need to worry about the image at all. Now, just like with those plexuses that are going to form nerves that feed like our arms and legs, our autonomic nervous system and those neurons of the sympathetic and parasympathetic divisions can create what we call autonomic plexuses. And these are found specifically in the thorax, so your chest, as well as the abdomen and your pelvis. Okay, and it's both axons of sympathetic and parasympathetic nervous systems. Okay, many of these are going to lie along major arteries, which you can see like this is your aortic arch, which is the first blood vessel that receives blood from your left ventricle when it pumps blood out. All the stuff there in yellow is the nerves and the plexuses surrounding things like your aorta, and then down here in the abdomen below that diaphragm that I've talked about this morning. We call these autonomic plexuses, and they include in your thorax the cardiac and pulmonary plexuses, and in your abdomen and pelvis the celiac, superior mesenteric, inferior mesenteric, hypogastric, and renal. As far as the image goes, and really most of the information, I just kind of want to introduce a little bit of autonomic nervous system stuff. For those of you who are in phys, we cover that in much greater detail. You don't need to know this image. I just wanted to introduce it just briefly for you. So we'll stop here on this picture. Questions?